And I'm now very pleased to introduce Dr. Lamb, our very popular first speaker. And he is a physician. He received his doctorate from Memorial University of Newfoundland. He completed his residency in psychiatry at McMaster University and then proceeded to a one-year clinical fellowship in geriatric psychiatry. He is currently the medical director of Halton Geriatric Mental Health Outreach Program. And we're really pleased to have him tonight. And I'm now going to turn it over to Dr. Lamb.
Good evening. Hi, I'm going to make sure I'm going to get this started first. And can Sandy or somebody just let me know if this is showing up properly?
Yes, it is. Yep,
okay,
you're good.
Great.
You're
Thank
good.
you. Okay, so the aim of tonight's talk is really to kind of provide us some basic information about dementia and kind of common types of dementias for family members so that they have a better idea of what this disease looks like and how it starts and how it progresses. And the whole purpose of this is to try to provide some information so that you can make good decisions and for you and your family member and your loved ones, and really kind of get that future planning component of the care underway if it's not already done, if you haven't already done so. So hope this will be helpful. This information series is really kind of geared to people without kind of any major kind of previous information about dementia or the signs of dementia. So it's really meant to be at kind of a basic level to help all people to kind of understand things better. Okay, so without further ado, I'll press on and seem to, okay. All right, so the goals tonight really is, first of all, to define what memory is, describe the different types of memory that we have, discuss the common types of memory changes as we get older, discuss what dementia actually means, because I think people have different ideas of what dementia actually means. We'll discuss 4 common types of dementias that are common in seniors. We'll talk about some medications that might be helpful for people with the Alzheimer's disease. We'll describe some of the complications that can occur that doesn't involve memory, so things like depression and other things that can occur. And we'll also describe some of the side effects that can come with medications that are used to kind of help people manage this disease. So first of all, I think in our society anyway, we have a lot of kind of stereotypes and misunderstandings about aging and forgetfulness. We know that memory is a mental process in the brain that is quite complicated and can generally be kind of broken down into kind of 3 basic steps. So the basic steps include registering information, storing that information, and then retrieving or recalling that information. And what I usually kind of like to give an example is almost as if a container ship is coming into port and they register the container, then the harbor, they will kind of store the container in appropriate storage places in the harbor, and then retrieve it accordingly to go to wherever the destination of that container is supposed to be. So it's kind of that registration, storage, and retrieval that kind of is the 3 basic hallmarks of what our memory does for us. Now, different parts of the brain is responsible for different things, as you can see from this diagram. And what we do, I want to point out to you, is that the parts of the brain that are really important for memory and laying down of memory is what we call a temporal lobe. That's kind of the side part of your brain. But the other part of the brain that's important is also the frontal lobe, which is almost like the file cabinet. It kind of sifts through and organizes the memory accordingly. Because not all memory is just information. Some memory has to do with sounds. Some memories have to do with sight. And so when we talk about memory, it isn't just strictly about information and knowledge. This diagram just shows you just the area of the brain that's really important for memory and laying down a memory. And here you see this flashing part of the brain called a hippocampus, which is very important for memory and for humans. As I mentioned before, memory and information storage can involve all kinds of information, not only data. They can also be things like memory of songs, recognition of places and people, and those types of information are stored in different parts of the brain. So once information comes through, it goes through your frontal lobes, kind of organizes and pushes that information to be stored in appropriate places. But the main part of the brain that's really important for memory, as I mentioned before, is the hippocampus. For simplicity, I'm going to break down memory in humans into two general components. And the general components are what we call procedural memory and declarative memory. Procedural memory is just, it's kind of more to do with motor memory. So procedures of learning how to like ski, how to shoot a puck, how to ride a bike. Those are kind of things that involve our motor skills or procedures. But when we talk about memory problems, when people come to us complaining about memory problems, what is the type of memory that's most significant is declarative memory. So learning of information, knowing about something. And that declarative memory can be further divided into semantic memory and episodic memory. So semantic memory is about knowing about something like who's the Prime Minister of Canada, who, things like that, versus episodic memory, which is kind of knowing about when certain things happen. It's kind of almost like a little diary. When's the last time you went to a movie, things like that. So that kind of information. So when we talk about aging of forgetfulness in people, we oftentimes hear the term amnesia. And amnesia is just defines as a loss of memory or a memory problem. But when we think about dementia or memory problems in seniors or in Alzheimer's disease and things like that, we don't really talk about trouble remembering things from the past. What we're actually talking about is having trouble learning new information. Because what happens is that it's not that we necessarily forget the things of the past. Eventually that happens too. But how it starts off is actually having difficulty learning new information. So if you are having trouble registering the information, storing the information or retrieving the information, then you're going to have difficulties recalling the information or remembering the information. So when we're talking about people with dementia or Alzheimer's disease, which is a type of dementia, we're not so much thinking about what they cannot remember from the past. What we're actually seeing in the beginning anyway is actually difficulty learning new information. And this is a slide that kind of makes things a little bit more complicated. So what we're talking about here is not remembering things from the past, what we call retrograde amnesia, so having trouble remembering the past. What we're talking about in dementia is anterograde amnesia. So again, difficulty learning new information. So one of the things that in our society oftentimes is a bit of a stereotype is that we think that just as we all get older, we're automatically supposed to lose our memory, and that which is not true. Memory loss is not a normal part of aging. Most people remain pretty alert as they age. And the things that we do see sometimes changing are things such as decrease in how fast your brain works, the processing speed, maybe a decrease in your ability to kind of register information in the sense that it takes you a little bit longer to do so, a decreased rate of recall, so it takes you a little bit longer to remember things. And decreasing your ability to kind of hold small bits of information in your brain, what we call working or memory. So, remembering a phone number or 6 digits or something like that. But certain areas of our memory, certain types of memory, I should say, that actually improves over time, generally that we see is a memory of factual information, general word knowledge, grammar, and generally overall, our language is preserved as we get older. Um, and as well, things like procedural memory, so learning to, knowing how to ride a bike or swing a golf club, things like that, those motor types of memories are less impacted by aging. So this screen kind of shows some terminology that is a little bit dated. Um, so but the concept is still important to know. So the concept of what we call mild cognitive impairment, and there's been different terminologies for this condition. The new terminology that we use today is called mild neurocognitive disorder, as dementia has now been replaced by major neurocognitive disorder. However, I think it's still useful for most lay people to kind of talk about dementia and using the concept of mild cognitive impairment. And what mild cognitive impairment is basically having short-term memory problems. So learning new information. Um, it's noticeable not only by the person themselves, possibly their other people who they are in relationships with, and also noticeable on formal memory testing or pen and paper tests. But it's really kind of limited to just the memory itself. It doesn't impact your language. It doesn't necessarily impact the ability to do things, or your ability to organize, or impact your language and recognition abilities per se. And it doesn't really impact on your day-to-day functioning at all. Um, that's what we mean by mild cognitive impairment. When it starts to impact other components of your brain functioning, so not just your memory, but language, or you're having trouble remembering how to do things that you used to be able to do, or having trouble recognizing familiar places, or having more trouble organizing your day-to-day, such that it actually does impact on your day. So things such as forgetting appointments, forgetting how that you had paid a bill already and paying it twice, things like that. When it starts, when your memory plus other brain changes become so prominent that it affects your day-to-day, then that's when we call it a dementia or a memory disorder. So this diagram is just to kind of highlight that there is a continuum. As we get older, yes, like everything else, our bodies and including our brain functioning does slow down. And we do see certain changes in our speed of how fast we think, how fast we learn information, and that's kind of considered part of normal aging. But then sometimes it evolves into a more severe memory problem. So short-term memory problem, you have difficulty learning new information, but it's really restricted around that. It doesn't affect your language or your abilities to do things or your recognition abilities or your organizational abilities, and it doesn't impact on your life significantly. And sometimes that condition evolves into a full-blown dementia, or now the new term is major neurocognitive disorder, where you not only have difficulties learning new information, but it does start to affect your language. So people may complain of word finding difficulties. They may find that their ability to use electronics or appliances is not as good as it used to be. They may also notice that they have trouble orienting themselves to even familiar places. And sometimes people can also notice difficulties with sequencing, abstract thinking, planning, just basically organization or higher functional abilities of the brain is becoming slowed down or impaired, again, to the point that it affects their day-to-day functioning. And that's when people cross the line and it becomes a diagnosis of a dementia. Dementia is a Latin term, like most medical terms. It comes from Latin or German or some European Middle Eastern language. It is not a disease on its own. It is a descriptive umbrella term that's used to describe a group of symptoms. And as I mentioned before, in order for it to be a dementia, it has to be not only a loss of mental abilities, but it also has to interfere with daily life. Oftentimes, dementia, and the most common type is Alzheimer's disease. The most common presentation initially is gradual short-term memory loss. Again, that's more indicative of difficulty of learning new information, but it can progress over time to the point where it actually interferes with long-term memory as well. So remembering things that happened 20 or 30 years ago. Usually, memory changes affect short-term memory first. That can eventually progress to affect other parts of the brain, which is responsible for difficulty with performing daily tasks, problem solving, trouble recognizing people, places, and objects, having more trouble with language skills, whether that's word finding or language comprehension. It may even affect their reasoning and judgment and problem solving skills, for again, which is more related to the frontal part of the brain. And sometimes it can affect a person's personality, and it can even cause behavioral changes like increased anxiety, increased depressions, hallucinations, paranoia, things like that. So before I kind of talk a lot more about dementia, I want to also talk about the other D conditions that can mimic a memory disorder in seniors. And one of the common ones that occur is a condition called delirium. It oftentimes is mistaken for dementia because it also affects the brain and affects their not only their memory, but sometimes their level of consciousness as well. And here, the hallmark is that people have trouble paying attention. Their mind is easily distractible, and really they're not able to make use of information in a way that the brain can able to understand. The mental functions the other hallmark is that the mental functions can fluctuate, meaning that one part of the day they can come across as being very confused, and then literally 2 or 3 hours or 4 hours later they can be a little bit more sharp and back to almost their normal selves. Um, However, the distinguishing thing about the delirium is that the onset of this kind of acute confusional state can be within hours or days, compared to a dementia, which often takes months to years to show itself. Um, a delirium is a very important diagnosis for medical people to recognize because oftentimes it's related to a biological cause, meaning that it may be related to an infection, it may be related to pain or a nutritional deficit or um, immunological deficit or endocrine deficits like diabetes or thyroid problems. It can be related to medications, drugs. It could be related to a number of what we call organic or medical or biological related problems. And usually it's a matter of recognizing that it could be a delirium, uh, looking for the cause or causes, and then managing it. Classically, the understanding is that once you find the offending agent or cause of the acute confusional state, then generally people confusion resolves, fairly fast. However, what we do find, or what we do know now, is that people who have mild memory problems already to begin with, sometimes the clearing of the delirium can often take longer than what we anticipate. And sometimes residual symptoms or symptoms that are left behind from the acute confusion can actually last for weeks to months, even once the offending condition or medication or what have you that caused it in the first place is resolved. The other D condition that we want to look at is depression. And depression is in there because oftentimes people will think of depression as, oh, I'm just sad. But in medicine, we think of depression more than just a feeling of sad. There are other clinical symptoms that we can find with depression. So not only a depressed mood or sad or blue mood, but it's usually associated with changes in your interest to do things. So sometimes people have just have no kind of motivation to do things when they're feeling very depressed. Their sleep may be affected. So meaning that some people may find that they're sleeping more when they're depressed, but more times than not, when people are depressed, it impacts their ability to sleep. They can also, in addition to a loss of interest, they also complain of poor concentration, difficulties paying attention, difficulties with energy level, problems with their appetite. And sometimes it could be an increase in the appetite, but more times than not, from my experience, is people with depression have a lower appetite. And sometimes depression or symptoms of depression can be to become more complicated to the point that people may actually have thoughts of wanting to be dead. So that is kind of why something that, like depression, we have to rule out, not only because it's not good for your mental health, but depression is found to have real impact on your physical health, like complicating heart disease, complicating diabetes control, but also complicating things like dementia as well. However, even if you don't have a dementia and you're a senior, sometimes having a depression may make you look like you have a memory problem, because as I mentioned before, one of the hallmarks of depression is actually problems with concentration or paying attention. So when you're really depressed, it's sometimes, and well, actually, I wouldn't say even when you're really depressed, sometimes when you're even mildly depressed, you have trouble paying attention and concentrating. And when you don't pay attention, the chances are that you may have more trouble laying down or registering new information and storing it. And if you don't register it properly and you don't store it properly, then there's a likelihood that you're not going to be able to recall it or retrieve it properly either. So it may come across as a memory problem, but in fact, it could be a depression. From experience, I find that many seniors who may have depression, oftentimes because of that apathy or lack of interest, they don't kind of feel up to being kind of asked questions by doctors to kind of see how they're doing. Most times, one of the telltale signs that sometimes people are depressed is that they answer a lot of questions with "I don't know," because you just can't be bothered with answering the questions because they're feeling so down. But again, that's just kind of a rule of thumb. But it is something that we need to kind of review when people come in complaining about memory. It is something that's reversible, like a delirium. So like a delirium, the depression can be treated. Now, mind you, the depressions don't come on as fast as a delirium, which come on hours to days. A depression may take days, weeks, sometimes months to manifest itself. But again, it's still a shorter time period compared to dementia, which oftentimes takes months, and oftentimes years for it to show itself. So that's kind of how you differentiate between the delirium, the depression, and the dementia. Okay, so this is my cat Simon. He's walking the Rainbow Bridge now. He's no longer with us. But again, anytime you see my cats, you know that there's a natural uh, uh, kind of break in the flow of the talk. So we'll likely be heading into another section. So the section that we're going to talk about more specifically is about the other D, which is dementia. So remember, when we see seniors in the medical field, when we see seniors who are coming in and presenting with memory changes or difficulties with remembering things, the dementia is not the only thing that we keep in mind. We also think about delirium, depression, and sometimes also drugs. With the day and age now that marijuana and things like that are legal, and certainly alcohol can also be considered is a drug as well, and we also have to keep that in mind. But for now, we'll be kind of from here on, we're going to be focusing most of our talk on dementia. And although there's anywhere from 60 to 70 types of conditions that can fall into the dementia category, the four most common culprits are Alzheimer's disease, vascular dementia, Lewy body dementia, and frontotemporal dementia. So in general, we do know that the population around the world, there is a silver tsunami, as it were, actually is here. The first baby boomers who turned 65 occurred in 2011. And so every year since then, more baby boomers have turned the corner and have become technically seniors as they reach the 65-year mark. Now, the good thing is that many of our quote unquote seniors now are much, much healthier. And the 65-year-old people are probably the new 45 or 50. But nonetheless, it is still the cutoff. When we think about seniors, is the arbitrary cutoff where people meet the criteria of being a senior. Okay. We also do know that the 65-year, as we talked about, the silver tsunami is the fastest growing proportion of the population. Is growing quite quickly, and the 85 plus category is growing quite fast as well. So by next year, and this slide is a little bit dated, it's about 10 years old now, but basically, we're thinking that close to 7 million people or 7 million Canadians will be seniors by this time next year or thereabouts. So approximately 18% of the population. In terms of looking at who may be at risk for getting dementia, we do know that despite a number of risk factors, the most common cause for dementia is age, or risk factor for dementia is age. And we know that as you increase age, the risk for developing dementia also increases as well. And we also know that looking at the numbers from studies, that the risk for dementia doubles every 5 years after the age of 60. And just in that slide, it just kind of shows you some of the predictive numbers moving forward in terms of the number of cases of dementia in Canada per year. So again, these numbers go back for the last 20 years. And as we can see that by 2038, we'll have close to more than 250,000 new cases annually in Canada, which kind of turns out to be about one case every 2 minutes compared to the last decade where we've had on average 100,000 to less than 200,000 new cases of Alzheimer's disease specifically per year, which is about one new case every 5 minutes. And this slide is just to look at the global burden of dementia and how much toll, financial costs, time taken away from caregivers, things like that. And it just kind of shows you the global impact of this disease. Now, just to kind of keep moving, in terms of dementia, the most common types of dementia, like I said, there's probably 60 plus types of dementias, 70 plus types of dementias, but the four most common types are the ones that we're going to cover tonight. And by far the most common type is Alzheimer's disease. And depending on the medical literature or that reference that you look at, Alzheimer's disease can be anywhere from 50 to 60, and some sources will go as high as 70% of all dementias are Alzheimer's disease. So oftentimes we kind of teach young doctors and learners is that if somebody comes in over 65 years of age and they've been diagnosed with a dementia, if you say Alzheimer's disease is the cause of the dementia, you'll be more than 50% right most of the time. Okay, so that's how common Alzheimer's disease is. It was first described by Dr. Alois Alzheimer's, and actually he was a neurology resident at the time when he first described the case of his index case, which is a lady by the name of Auguste D. Auguste D was a 51-year-old lady who exhibited decline in her mental function. But in addition to the decline in the mental function, she also presented with what we call neuropsychiatric symptoms. So symptoms such as paranoia, having hallucinations where she sees things or hears things that are not really happening. Not so much that they're fabrication of, it's not so much that she's making it up, it's really the brain kind of making sense of her environment and misinterpreting and trying to fill in the blanks of things that it doesn't understand. And sometimes when your brain tries to make sense of the world by filling in information that it thinks is there, is when sometimes some of these symptoms do arise. Now, the one thing I would say here is that Auguste is not the typical case of Alzheimer's disease as we know it today, primarily because of her age. She was very young, even by today's standards. She's just is very young, um, and um, and the thing is that not only did she have the mental function changes, some memory problems, but she had prominent, what we call, as we said, neuropsychiatric symptoms. So usually they don't kind of come on this early. So this means that this lady probably had these symptoms for a while, which means that when she first had these symptoms, she was probably younger than 51. She was probably in her 40s. So here on your screen, you'll see a picture of Dr. Alzheimer's and his first uh, patient that he talked about in terms of the symptoms of what we now call Alzheimer's disease. The exact cause of Alzheimer's disease, we really still don't know. We really don't kind of know why the whole process starts. We kind of get a general sense of what we sometimes see when we do investigations of and scientific review of people with Alzheimer's disease. And we do know from those cases that the two hallmarks of this disease or evidence of this disease in the brain is the development of plaques and the tangles, or the amyloid plaques and the neurofibrillary tangles. In addition to these hallmark traces, evidence of Alzheimer's disease, we also see that the overall size of the brain does shrink, and that's due to dying of brain cells, and that leads to the general shrinkage in brain size. But we also know that in addition to losing matter in the brain, there's also decreasing brain neurochemicals, or chemicals in the brain that's responsible for the process of memory formation, storage, and retrieval. There's increasing data to suggest that there may be an inflammation component to these brain changes, but much more science needs to be done to kind of elucidate this part of the process a little bit more. This is just a slide showing you the plaques and the tangles. So A is a picture slide of the brain of the brain tissue, showing kind of what we call the tangles, where the arrows are pointing to, and the tangles are actually uh, brain cells, neurons that have died. And what that process involves is that somehow the Alzheimer's disease process causes the skeleton or the bracing structure of the brain cells, the neurons, to fold improperly and eventually to collapse on it into itself. And so you kind of almost see, it's almost like a scaffolding collapsing down on itself. So you kind of see those tangles and the pathology or the tangles are actually seen inside the cell, while slide B shows the plaques. And the plaques are kind of just kind of groups of toxic material that we'll talk about shortly, that kind of clumps together and leaves the cell. But even once it leaves the cell, it continues to aggregate together, forming these big plaques. So what we usually see are these plaques are what causes the damage between the neurons. So it causes damage such that the one neuron cannot communicate with another neuron. And that's kind of not only causes trouble with transmitting information and learning new information and storing new information and retrieving new information, but that whole, once the accumulation of the plaques in the brain is enough, it becomes so toxic that it actually starts to kill the brain cells around it. So in this slide, it really shows you kind of where the plaques and the tangles starts, or where the pathology starts in the brain. So as you can see, there are some parts of the brain that are familiar that we talked about. So it includes things like the hippocampus, and that part of the brain where the hippocampus lies. You see the amygdala, the entorhinal cortex, inferior temporal cortex. That whole area is what we call the temporal lobe. And we talked about that earlier in the diagram before. This is the part of the brain, area of the brain that's really kind of very important for the memory process. And in that picture, you see that those colored structures, the amygdala, the hippocampus, that area, you see these kind of little grains, dark dots, almost like pepper. You see how concentrated they seem to be in those structures, and then in the temporal lobe. And as you move out, you still see those little spots, but they're not as highly concentrated as it is in the temporal lobes. So what this actually shows you is that the pathology does start in the temporal lobes. We just don't know why and how, but that we do know that's generally how where it starts. And as the disease progresses, because the disease is not stagnant, the disease, once it starts, it keeps going, and it spreads from the temporal lobes into other areas of the brain. So it starts off as a learning new information problem, but eventually it would start affecting your language, which is also in the temporal lobes. It would also affect your ability to organize as it spreads into the frontal lobes or the prefrontal cortex, and then it will affect the rest of your brain moving forward. And eventually, once it starts affecting all the brain, it will start moving inwards, and so people will start eventually at the later stages have difficulties with coordination, movement, walking, and so forth. And this slide is just kind of shows you in terms of what one can see as Alzheimer's or other dementia progresses over time. So in slide A, the picture A, you will see kind of size of generally a normal brain. And in a normal brain, you see kind of these twists and valleys. So you see these lumps and kind of valleys in the brain. And certainly once the disease starts, and in addition to the plaques and tangles, as I mentioned before, you also see shrinkage of the brain, which kind of corresponds to neurons or brain cells dying. And as you lose more of those brain cells, you see how not only the size of the brain shrinks over time, but you also notice that those valleys around the kind of irregular worm-like structures become much wider. So you can see that there's much more distance between the swining areas of the brain, and you see more of the enhancement of the spaces in between, or what we call the valleys. So right now, like I said, we still don't know why the disease starts and the exact process. We do have some theories, and one of the longest theory is called the amyloid hypothesis. We do know that the amyloid hypothesis is not sufficient to understand Alzheimer's disease as we know it today, but it certainly gives us some idea about the possible mechanisms that can occur, although we pretty much agree now that the amyloid hypothesis itself is insufficient to explain everything. So in the amyloid hypothesis, it really kind of looks at a special kind of protein or structure or the brain that's in the brain called amyloid precursor protein. And amyloid precursor protein is something that all of us have in our brain. It's actually a normal kind of part of the brain. And generally, with everything in our body, our whole body is it's a kind of like a factory. Things are produced, recycled, reused, or destroyed to give us energy and blood flow and things like that. And not only do we take in new energy by food and water and things like that, but the body also sometimes preserve by recycling things as well. And how that occurs in our body not only occurs with chemicals, but it also occurs with things called enzymes, which are kind of like things that help catalyze the making and breaking down and recycling of things in our body. So what we do know is that generally this amyloid precursor protein, which is on the surface of the brain cells. So in this picture, you see kind of this semicircular structure in purple, in solid purple. That's to represent the cell coating, the outer part of the cell, or the barrier. And on that barrier, there's a lot of protein and different things that are on it to help it communicate with other cells, and there are chemicals that come on and off and recycle through and catalyzed by things like enzymes and to kind of make the body and the cell work and do what it's evolved to do. So generally, with these amyloid precursor proteins on the nerve cells. Generally, normal aging causes the process to occur such that um, the amyloid precursor protein become processed in a erroneous way. So it's almost like if you can think about a car factory like Ford, where there's a conveyor belt, and suddenly something happens in the factory where the engine block is put in improperly. So this is kind of the same idea that the process in the body is humming along in what it does. But as we get older, something happens where the process, the flow of the conveyor belt of these particles and these proteins are not processed properly, and it develops something called beta amyloid. Now, beta amyloid in itself does not cause too much damage. And in fact, initially when it's cleaved or kind of set on by the enzymes and produce beta amyloid, it's inside the cells. And in itself, it doesn't hurt. But all the amyloid eventually gets extruded or pushed out of the cell and goes into the surrounding area between the cells. And this in itself is okay, but what it does is that these plaques, these beta amyloid, uh, start to congregate and aggregate together to form bigger entities called plaques. And it's these plaques that are between the cells in the brain that starts to kind of clog up the information highway, that starts to cause damage to this information highway, damages the brain's ability, the brain cells' ability to communicate with each other and to coordinate actions and activities for us, which include registering, storing, and retrieving new information. So at this point, I normally have a video to show, which I won't be able to show tonight because the way that we're doing virtually, I can't get the video on the computer. So what we can do one of two things. We can either push on and continue on with looking at the types of dementia, or I know it's only 7:15. I don't know whether Sandy wants to take a kind of short break at this point in time, or shall we just push on?
It's 7:45, so push on 15 minutes maybe,
Sure, okay.
and
All
then we'll
right.
take an intermission. Thank you.
Okay, so we'll do that. So to stay with Alzheimer's disease, so we talked about risk factors before, and certainly, as I mentioned, the most common risk factor is actually age. That's a risk factor that's not changeable, it's not modifiable. Anyone who gets old enough eventually may get this disease, and some experts will tell you that if you long enough, you will get Alzheimer's disease or some form of dementia. Just because your brain is aging, and it's that process that increases our risk for developing these types of conditions. Now, having said that, there are also genetic factors that puts us at risk for Alzheimer's disease. So most times Alzheimer's disease is a sporadic disease that occurs, and that there is some risk if there is a family history um, for you. However, there is another type of Alzheimer's disease where having a positive family history can be significant. And we'll talk a little bit more about the familial form of Alzheimer's disease later on, but certainly even the sporadic form, which is the majority of form of Alzheimer's disease, even having somebody in the family does increase your risk slightly. Having a history of vascular disorders like stroke, TIAs, things like that can also cause increase your risk for Alzheimer's disease. We know high blood pressure is a risk factor for Alzheimer's disease. We also know are starting to accept and having more evidence to show that diabetes is also a risk factor for Alzheimer's disease. And again, that kind of makes sense given that diabetes also affect your vasculature as well, like the blood vessels in your body. Having certain genetic, not an abnormality, but a kind of a genetic variation of one of your genes can put you at slightly higher risk as well. So there are some risk factors that we know of. But again, having said all that, the most significant and most reoccurring risks that we've seen in studies over and over again is age. Alzheimer's disease can be broken up into two common forms, as I alluded to earlier. The majority of us who may be at risk and who may develop this condition will have a sporadic form of Alzheimer's disease, but there is a small percentage of people who have what we call familial or early onset Alzheimer's disease. The familial form is by far the less common form. It comprises about 5 to 10% of all Alzheimer's cases. And these are people who develop symptoms much younger in an earlier age. They can have symptoms as early as in their 40s and 50s, although I've seen some reports, not very common, but some reports indicating that some people will start having symptoms in their late 30s. This form of Alzheimer's disease is highly genetically dependent. So we know that there are actually abnormalities on chromosomes 1, 14, and 21. And anyone who has a abnormality or a mutation in this gene and in these genes will eventually develop Alzheimer's disease. Luckily, if we're going to get Alzheimer's disease, this is the one that I would pick. Not that I would want it, but certainly if I were to have it, the sporadic form is by far the most common form. It affects 90 to 95% of cases of Alzheimer's disease. It's what we call the late onset form. And when we say late onset, we kind of arbitrarily talk about the age of 65 and over. So arbitrarily 65 and older is what we call late onset Alzheimer's disease. Younger than 65 is what we call early onset Alzheimer's disease. And in the sporadic or late onset form of Alzheimer's disease, the genetic kind of load or significance is less. So we don't have an abnormality that sets up at a higher risk of developing sporadic Alzheimer's disease. It's more of a genetic variation where there are certain types of genes that does increase your risk, but won't necessarily mean that you will get it, compared to the familial form, which if you have an abnormality in the genes that I spoke about, then you will have that chance of, you will have Alzheimer's disease somewhere down the road. For Alzheimer's disease, as I mentioned before, the disease starts very insidiously, slowly, and it can progress fairly slowly as well. It starts off initially with short-term memory problems. So people have trouble remembering things that happened in hours, days, weeks ago versus things that happened 30 or 40 years ago. It then can evolve into affecting people's language, where people actually have trouble finding right words. They have difficulty with language comprehension. They make kind of progressively more grammatical errors. It also can affect their ability to recognize, even though their eyesight is intact. They have trouble identifying, recognizing things, common places, and sometimes people will start losing their ability to orient themselves to where they are, even around their neighborhood. They may even have trouble getting lost. They also have difficulties remembering how to perform certain tasks, even though their ability to move their hands or what have you are intact. People oftentimes find that using electronics or appliances may be challenging. As we talked about earlier, problems with complicated functions like sequencing, abstraction, or any kind of task that takes more than 2 steps to complete, people may start having more trouble because their ability to kind of organize and things like that is impaired. So oftentimes when we talk about Alzheimer's disease, we talk about everything has a start. Has a beginning, middle, and an end. So in the beginning of Alzheimer's disease, the problems may come across as short-term memory problem impairment, but also, and that shows itself in kind of the day-to-day functional impairments, such as things like balancing a bank book, preparing a complex meal, managing a difficult medication schedule, forgetting appointments, and also driving as well. They may have trouble kind of coordinating themselves to drive in a safe manner. And as the disease progresses, even making simple meals is complicated for them. They have trouble doing household cleanups, chores, difficulties using common items, like I said, appliances or electronics. The remote control, TV remote control is one of the biggest things that people with Alzheimer's disease sometimes find themselves having trouble with in the beginning. They may have trouble remembering parts of their own personal history. They may forget names of grandchildren. They may exhibit some personality changes. People may be grumpier or sometimes more mellow. They have trouble with direction. So as I talked about before, they may have trouble recognizing even familiar places, such that they have trouble not only with driving, sometimes which shows itself as getting lost, but sometimes people even have trouble finding their way home after going out for a walk. And then also just aspects of their own care, like bathing, dressing themselves without assistance or supervision, ability to toilet themselves properly, hygienically, things like that may start to be affected. The severe stages, even things such as basic activities like feeding themselves, grooming themselves, toileting themselves become more problematic or start to occur. Problems communicating to others, making their needs known in a coherent way or in a way that people can understand. They may even have trouble with movements, or they may show themselves as being more walking stiffly, or you're noticing that they have more tremors. Eventually, it may even progress to the point that they have trouble recognizing family members. And at this point in time, this is definitely in the middle stages, if not more advanced. Most of these people will require some form of supervision. And then as the disease goes into the more advanced stages, people will have trouble really even making sense of their environment, surroundings. Sometimes people become less conscious, so they spend a lot of time napping, or really not even kind of interacting significantly in a meaningful way with their environment. And they become much dependent, or really dependent, on their caregivers. So by the time the profound stages occur, people's brain is really kind of functioning at a developmental equivalent of maybe somebody who's between 1 and 3 years old. And then at the end stages, people who reach this stage are generally bedbound. They require constant care. They're very susceptible to accidents and infections. People will start developing difficulties with coordinating even things like swallowing, which increase their risk of kind of swallowing the wrong way and causing what we call aspiration pneumonia. And oftentimes, if people are living long enough to this part of the dementia, what usually takes them is exactly that. They have trouble with swallowing properly, and they develop a pneumonia, and then they pass from that. In terms of kind of progression of the disease, depending on when the disease was diagnosed and uh, uh, kind of aware of, there could be anywhere between of 8 to 10 years between the onset of symptoms and passing away from the symptoms. But we've had reports of people surviving for more than 10 years with this disease. So, so that the rule of thumb of 8 to 10 years from time of diagnosis to the end, if they reach that point, is kind of the average that we see. So in terms of the Alzheimer's disease, how do we kind of diagnose it? Generally, it's by autopsy or by a brain biopsy. We look for the amyloid plaques, and we look for the tangles, the neurofibrillary tangles. The diagnosis, because we don't do brain biopsies on many people, Um, Usually the diagnosis is made by physicians or nurses or other medical health professionals who take a very good history to not only look at how the memory changes occur, but what the pattern looks like, the time, looking at how it affects their day-to-day, and how it impairs and what other kind of associated symptoms come with it. By taking good history, we're accurate about 80 to 90% of the time, which is pretty good. But again, like I said, to be 100% sure, that would require something like a brain biopsy or what have you. Now, there are certain types of imaging or scans of the brain that can be helpful. So things like a PET scan, where a compound, or usually a radioactive compound, is put in your blood system, and then it follows through your circulatory system and then into your brain. And depending on how your brain takes up this tracing compound, we get a sense of where in the brain you have these kind of plaques and tangles. So we do have compounds that specifically kind of attached to these plaques and tangles, and when you light them up in a PET scan, you can kind of see how much plaques and tangles you may have in your brain. However, the PET scanning and those things are still really in the research phase of development, and it's not something that we use commonly at all in our system here. Sometimes Toronto, in Sunnybrook, and some of the more specific kind of locations will sometimes do these types of investigations, but most times these investigations are not necessary. Usually, by taking a good history, we're very accurate. So in addition to taking a good history, we also do mental status evaluation. So we kind of look at things like anxiety, depression that could be causing trouble with memory. We do a physical exam to make sure that you don't have a medical condition that may be contributing to memory changes, as well as doing laboratory tests to make sure that things like you're not low on blood, or you have trouble with your thyroid, or trouble with your salts in your body that might be affecting your memory. And we also do a psychiatric evaluations to kind of look at things like depression and other things that could become causing you to have these symptoms. Okay, so I think that, right now that's 7:58, 2 minutes to 8. I'm gonna stop here because Wellington is my other cat, and this is kind of another natural break in our talk. So I'll take make a kind of intermission here.
That's great. Yeah, we'll just take the seventh inning stretch here, 5 minutes. Go make yourself some popcorn, refresh your tea, and we'll be back in 5 minutes. Hello, Dr. Lamb. Did you see the 2 questions that I sent to you?
Under the Q&A?
Yeah, the Q&A.
Why are more women more likely to develop Alzheimer's disease? Is it mainly because of hormone difference or due to longer lifespan? It's the latter.
I'm sorry,
It's the latter. It's because they have a longer lifespan. Men usually succumb to cardiovascular disease or some other issue that it's basically based on the fact that women live longer. The hormone route has been looked at, and there really isn't much evidence to support that.
Okay.
Yeah.
Thank you.
And then
the other question, sorry, did you see that one?
If a loved one has Alzheimer's disease and lives alone, would you suggest taking the chance to visit with the current COVID restrictions in place? Are they considered to be immunocompromised? Well, I would not say that they're immunocompromised unless they have another disease condition that would make them immunocompromised or defined as immunocompromised. If they have Alzheimer's disease, lived alone, would you suggest taking a chance to visit them? It really depends on their stage of disease and how they're functioning. So it's kind of hard to kind of say without kind of knowing more about their specific situation. And is paranoia part of delirium or dementia? It can be part of both, actually. Zoom cut out at 7:40. Did I go into detail of SVD? Depends on what SVD is, vascular dementia or
I'm not sure.
Yeah.
Yeah, must be that particular woman's cutout, her Zoom cutout. Okay.
Okay.
Thank you for answering the questions. And if we have time, we'll answer some more questions at the end. That's great.
Okay. Alrighty. Shall I start then? Everybody, I guess everybody's back.
Possibly. We can't
Okay.
see them.
Okay.
We can
All right.
assume.
We're just gonna go then. All right. Okay. So we're gonna go. So we're gonna go on to the other types of dementia. So the next one we're going to look at is Lewy body dementia. So Lewy body dementia was once upon a time thought to be the third most common type of dementia. However, the more we learn about Lewy body dementia and the more people understand the symptoms that are associated with Lewy body dementia, in fact, it probably is the second most common cause of dementia and may comprise as many as 25% of all dementias. And what is Lewy body dementia? So Lewy body dementia are people who have symptoms of poor memory, as well as symptoms of Parkinson's disease. So these folks have presentation memory problems that are like Alzheimer's disease, but they also have a neurological or motor component that makes them look like Parkinson's disease. So they have tremors. They may feel stiff. You may notice that their facial expressions become more wooden. They don't have as much of a range in their facial expressions. You may find that their walking starts to become impaired. They seem to be a little bit more stiff in their walk. They shuffle a little bit more. They may be hunched over a little bit more. So it's almost like they're kind of walking in a suit of armor. In addition to the motor changes, you can oftentimes see people experiencing delusions, which are fixed false beliefs, but really more of a hallmark of Lewy body dementia is actually hallucinations. Now, mind you, most times when we think about hallucinations, we either think about hearing voices or seeing things. And certainly the visual hallucinations or seeing form of hallucinations is common in Lewy body dementia. But just to keep in mind that we also can have hallucinations in terms of our other senses as well. So we may have hallucinations where we taste things that are unusual or not the way they're supposed to taste, or we may smell things like gas where there really is no such thing, or we sometimes may feel like there's insects crawling on us or people touching us when there's no insects on us or people touching around us to cause that sensation. But certainly in terms of people with Lewy body dementia, visual hallucinations, seeing things is quite common, and it actually comes on fairly early compared to people with Alzheimer's disease. People with Alzheimer's disease can have paranoia and certainly visual hallucinations too, but usually in the middle to later stage of the disease. So the common hallmarks of this disease is that people have symptoms like Alzheimer's disease, but they have motor symptoms, so the shakiness, the stiffness that you see in Parkinson's disease. These folks also have early onset of visual hallucinations as part of their presentation. And the other part of the presentation that I don't really talk about here so much is a fluctuating level of consciousness. So people's kind of clarity seems to fluctuate over the span of a day. So it's almost like a delirium, but not kind of like extreme as a delirium. Um, the other thing that for medical professionals to know more so than anything else is that there are medications that can be used, for example, to kind of manage paranoia or to manage hallucinations. And these medications are called antipsychotic medications. So medications that kind of bring your brain back into reality a little bit more. But people with Lewy body dementia are very sensitive to medications like that. The reason being is because that part of the presentation are these Parkinson's-like symptoms. And one of the side effects of those antipsychotic medications is Parkinsonism. So if a medication has a potential for side effects and you already have that problem, like Parkinson's disease, and you have a drug that could make that even worse, you can see how these people can be even more sensitive to the side effects of a medication like an antipsychotic medication. So it kind of makes sense. So that's kind of the sort of three cardinal features of Lewy body dementia is one, they have not only the memory problem, but two, they have the fluctuating level of consciousness or clarity. The other major cardinal feature is the Parkinsonism, and then the final cardinal feature is the visual hallucination. Vascular dementia was once upon a time thought to be the second most common cause of Alzheimer's disease, but as we do more research at it and looking at strictly what types of strokes or what needs to happen after a stroke to cause a dementia, the criteria changed such that if you look at needing the time criteria, meaning that you have to be within 6 months of a stroke to develop the dementia, you have to have CAT scans or MRIs to show that the stroke occurred in an area of the brain that causes these symptoms. When we kind of look at all these things together, we come up with people who have pure vascular dementia, about 15% or thereabouts. So it may be the second most common, but possibly the third after Lewy body dementia. This type of dementia occurs more often in people who are older and in men more than women. And again, that does just kind of make sense because men are more at risk of cardiovascular disease and women are. Vascular dementia are caused by a series of either continuous or long-term insufficient blood flow to the brain, or due to a stroke, which also is an insufficient blood flow to the brain, but it can be but the onset is very quickly. And the strokes in the brain can occur from two ways. You can either due to clots, so kind of clogging up the drain as it were, or due to the pipes blowing up. So you can either have a stroke from blocking a blood vessel in the brain or the blood vessel bursting. Either way, there's damage to the brain cells around there because your brain exquisitely needs blood and oxygen and sugars, glucose to function properly. And when you either have a blockage or a burst blood vessel, then you're not getting sufficient fuel to the brain. Your brain is highly sensitive to the needs of having fuel. And when it doesn't get it, the cells are very sensitive to damage. So in here, this is a autopsy of a brain, as you can see, specifically on the right side of your screen. You will notice that on the side part, the cauliflower shape, there's a reddish kind of marking there, almost looks like ground beef kind of texture and look. That's kind of an area of a stroke. So vascular dementia, risk factors for vascular dementia is pretty much similar to Alzheimer's in some cases, and the same as risk factors for a stroke. So things like high blood pressure, diabetes, high cholesterol, heart disease, abnormal heart rhythms like atrial fibrillation, things like that. Those are at risk factors for a stroke, which is a risk factor for dementia. And certainly high blood pressure and diabetes are risk factor for Alzheimer's disease. So vascular dementia and Alzheimer's disease have some kind of similar risk factors as well. And both of them, certainly age is an issue because all these issues with risk factors for stroke increase with age as well. Okay. Vascular dementia, the symptoms usually occur fairly quickly. As I mentioned before, Alzheimer's disease can occur months, but generally kind of onset is years, and it's fairly insidious, meaning that it's kind of slow in starting and slow in progressing. While symptoms of vascular dementia usually is a little bit faster, the criteria is to meet the definition of vascular dementia, there needs to be a proximity of about 6 months within that 6-month window between a stroke and the development of dementia symptoms. And the issue is that when people have a stroke, we know that with cardiovascular disease that sets you up for a stroke, it's likelihood that once you have one stroke, you likely have other strokes in the future. And why that's important is because every time you have a stroke, you can have a kind of a decline in your functioning acutely. And then although you may get a little bit better and recuperate, most times you don't recuperate back to your previous level. So you almost have this kind of what we call stepwise decline. So you have you're here, you have a stroke, you decline, you plateau, you're going along, but because you have cardiovascular disease, you have another stroke, you decline a little bit more, and then you kind of chug along for a while, and then you have another. So that's what they call a stepwise progression. And that pattern of progression is very typical of people with cardiovascular disease, but also people with vascular dementia as well. Um, and the presentation after stroke can be kind of variable. So not everybody who have a stroke will end up having a vascular dementia. Sometimes people may have trouble with weakness on one side or the other. So it really depends on where the stroke hit. If the stroke hits in the temporal lobes, as I showed you before, then there is more likelihood that you will have trouble with language or memory problems or ability to regulate your emotions and so forth. The other thing that people oftentimes hear about is TIAs, or transient ischemic attacks, or people call them little strokes or baby strokes, or other lay terms that are used to describe transient ischemic attacks. And the reason why they're not totally benign, even though most people who have, well, by definition, people with transient ischemic attacks kind of go back to baseline. They have a mini kind of episode, which is transient, and then they kind of get back to their normal selves. But what we do know is that this is an indicator of harbinger of things to come. So it's an indicator that you are at risk of having a full-blown stroke somewhere down the road. And that the reason why that's important is that even though we say that transient ischemic attacks, you don't have any permanent kind of functional changes or damage, we now know that, but when the scientists and the pathologists who look at cells, that even once you've had a transient ischemic attack or a TIA or a mini stroke or what have you, there actually is damage in the brain cells at a microscopic level. So it's not as benign or as safe as people think it is. And not that people think it's safe. I mean, it is it's letting you know that something is not right, but it certainly is not as benign as we once thought it was. And if you have enough of these TIAs over time, the accumulation of damage in the brain can be uh, as as significant as if you had a big stroke at one time. It's just that it took you longer to get there. So it could be an accumulation of damage that we could see over time that leads to dementia through things like TIAs. So how is a vascular dementia diagnosed? So it's that we have to diagnose it not only from history, but unlike Alzheimer's disease, you also have to find symptoms on neurological exam, like deficits, as well as appropriate uh, brain imaging scans that would indicate damage to that area that would cause these types of deficits. Okay. The other thing that we also know is that just because people have Alzheimer's disease or vascular disease or vascular dementia, I should say, is not mutually exclusive. So people can have some form of Alzheimer's disease as well as forms of vascular dementia as well. So having one does not preclude having another type of dementia on top of that. The fourth most common cause of dementia or memory brain disease that involves brain functioning is frontotemporal dementia. So this is a broad spectrum of disorders, which includes not only behavioral changes initially, but it will encompass memory changes later on, but it also can include early in its presentation changes in not only one's language abilities in terms of language production and comprehension, but it can also affect people's behaviors as well. So by the name frontotemporal dementia, we know that it predominantly affects the frontal lobes, which I mentioned before, is not only responsible for kind of the filing cabinet of memory, like it kind of sifts through and kind of sends the memory data to the appropriate brain areas, but it also is responsible for things like sequencing, organizing, planning, abstraction, kind of higher order functions. It also is an area that's responsible for motivation, personality, emotional regulation. So if we know that that front part of your brain is diseased, you can potentially see variations of the things that I just talked about. The temporal lobe, as I mentioned, is not only the area of significant for memory formation and kind of getting the whole memory registration and retrieval process kind of underway, but it is also responsible for language as well. So language, not only expression, but language comprehension, meaning understanding the meaning of words, okay? So there are people who can have no trouble speaking, but they may have trouble understanding what you're saying because they lose the meaning of words. They don't understand what the meanings of words mean. So they can speak easily, properly, no problem in terms of smooth production of language. But what they're saying doesn't make sense because their ability to understand language is lost, and therefore what they're saying doesn't make sense. While other people may have trouble producing language because the areas that's responsible for producing language is affected in the brain from dementia, but their comprehension of language is actually at another part of the brain. So if that part of the brain is intact, a person may have trouble speaking and say they have trouble like, I have trouble finding, finding what I want to, finding the things I want to say. And even when I turn on that thing up there. So they kind of talk around things, but their ability to understand what you're saying or what their message, what they're trying to get across is still intact. Okay. So just because sometimes people can't get their point across doesn't mean that their ability to comprehend language is affected. Similarly, just because people can talk smoothly doesn't always mean their ability to understand language is intact. Okay. So by looking at frontotemporal dementia, you have a variation where it affects a person's personality. So people will become unlike themselves. They start stealing, taking things, setting fires. So that's one type of frontotemporal dementia. But another type of frontotemporal dementia involves language as well. So that's why I said this frontotemporal dementia encompasses a variety of things. But if you understand what parts of the brain is responsible for, you kind of get a general sense of what they can present like. Okay. This is, again, one of the dementias that are common in early onset dementia. So when people think of early onset dementia, the two that come to mind usually for most medical professionals are either early onset Alzheimer's disease or some form of frontotemporal dementia, because usually the age of onset is a little bit younger, anywhere from 40s to 60s, versus the sporadic Alzheimer's disease, which can occur from 65 plus. Okay, arbitrarily cut off, but there you go. And again, as I alluded to first, generally what we see in frontotemporal dementia first isn't so much memory change, though that can happen later. What really sets us apart from other dementias that we talked about tonight is that it usually affects behavior first or language first. And when we think of frontotemporal dementia, most medical professionals will kind of think about the behavioral variant of frontotemporal dementia versus the language variant of frontotemporal dementia. They will think about people who are disinhibited, who are impulsive, who lack social awareness. They have trouble looking after their own personal hygiene. They don't bathe for days to weeks, and they don't seem to have a problem with that. They can be very repetitive and compulsive, doing things over and over again. So that part of that behavioral variant of frontotemporal dementia is usually what we think about, most medical professionals think about when they think about frontotemporal dementia. Okay, so we just kind of reviewed the 4 most common types of dementia or brain function disorders. This is my cat Simon. So we went from Simon, Wellington, and now we're back to Simon. And so we're kind of going into another part of our talk now. Management. So what do we do when we have somebody coming in? They present with memory issues. You do a good history. Probably sometimes, depending on the presentation, the physical. Sometimes, sometimes not. Sometimes we don't need to do the physical. But where do we go from there? We suspect that there is a dementia. How do we kind of address it once we have a index of suspicion, once we do our job and decide that, yeah, this is our provisional diagnosis. This is what we're probably looking at as dementia. What do we do then? So where do we go from there? So once we make the diagnosis, we look at kind of medical and reversible causes of dementia. Now, having said that, we do know that the reversible causes of dementia are very few. So things like thyroid disease, electrolyte imbalances, thyroid problems, B12 deficiencies, things like that. So some of those are reversible, but those are very few, to be honest with you. Most times when a dementia has been diagnosed, it's generally a non-reversible type. But we still make sure that we still do the medical component, the medical tests and things like that to make sure that we're not missing something that's reversible. Okay, so that's kind of the general approach. Then we look at behavioral and psychosocial interventions. So it's things like what you're doing tonight, educating yourselves, educating your family members, getting information so that you can future plan, ensure a person's safety, making sure that the powers of attorney are present, their wills are done, and things such as driving are reviewed. And also just kind of address any other legal issues in terms of if there's any risk, excuse me, any risks to themselves in terms of, excuse me, the finances and things like that. Regular health monitoring. So things like making sure your vitamin levels are okay, making sure that your thyroid's okay, making sure your diabetes is well controlled, making sure your blood pressure is controlled, making sure that if you have an irregular heartbeat, that's looked after as well, because irregular heartbeats, as you heard before, can increase your risk for stroke, which can increase your risk for vascular dementia. So regular health monitoring is important, as well as taking medications to kind of offset any kind of cardiovascular disease or reversible causes. And as we'll talk about later, medications that may help slow down the progress or progression of dementia. As what I talked about earlier in terms of safety, driving is always something that people worry about. Certainly, driving in North America and most Western countries is very common, really most of the world. But I think sometimes most oftentimes we don't think of driving as a privilege rather than as a right. And there certainly is not the case. And many jurisdictions, there is legal documentation to kind of talk about the obligations of physicians to kind of keep an eye on safety when we're dealing with medical conditions. And one of the conditions that we are obliged to report are people who have dementia. So, excuse me, once we made a diagnosis of dementia, we do kind of look at safety, and driving safety is one of them. And if we feel necessary, we would also suggest people go for a functional driving assessment. And these functional driving assessments are more detailed than kind of the driving assessments that the Ministry of Transportation do themselves. And in fact, the ministry doesn't do this type of testing. They kind of have certain specialized companies do this. The reason is it's fairly intensive. So it doesn't involve just writing a test. It involves kind of pen and paper and computer tests, as well as an in-car driving assessment. And the in-car driving assessments composed of not only a specialized driving instructor, but also an occupational therapist as well. So once you kind of do a functional driving assessment, once you kind of do the computer paper tests, and it's found that it's okay to move on to the next phase, which is an in-car driving assessment, that's when that part is done with the driving instructor and the occupational therapist. So this is a video clip of a couple of video clips of kind of people who have suspected dementia, who are going for their functional driving assessment. So we have a patient with suspected Alzheimer's disease who kind of drifts left of where he's supposed to be going and kind of hits the median. Okay, and here's another clip of the same person, the same test, where he also continues to drift left, and you see the instructor having to take evasive actions. Okay, so this is kind of just a demonstration that I think is really important for us to keep in mind, is that unfortunately there are a number of medical conditions, at least in Ontario, under the Highway Traffic Act, that kind of obliges physicians to report the condition. No physician is a driving expert, but what the Highway Traffic Act obliges us to do is to report conditions that may cause risk for driving or increase risk for driving, um, accidents. So they include things like certain types of diabetes, heart conditions, seizures, and so on. And in that list is dementia as well. So again, when we report, it's not something that we want to do. And certainly, we're not saying that we're driving instructors or driving experts. And it also doesn't mean that we're pulling your license. All we're doing was we're kind of living to the letter of the law. By the letter of law, and we're reporting a condition that we're obliged to report. And the Ministry of Transportation have physicians and other medical experts and other experts to kind of review the information that's sent in, and they're the ones that will determine what needs to be done when after that report is sent in. So going from kind of management to the treatment aspect of things. So medications that are used now is really to kind of manage mild to moderate cases, specifically of Alzheimer's disease, although there is some indication for use in Lewy body dementia, Parkinson's dementia, which we didn't really talk about. Um, but kind of more specifically, because Alzheimer's disease is the most common form of dementia, most of the medications have been developed specifically to manage that type of dementia. So the medication class that has been developed to try to slow down the progression of disease is called an acetylcholinesterase inhibitor. It's not a cure. It doesn't fix the problem, and it certainly does not give you back memory or function that you have lost. But what it does do is it tries to slow down the decline in your brain and its brain functioning, therefore hopefully keeping you in a home-like environment for as long as possible. Because clearly if the disease declines, not only is your memory is going to be affected, as I mentioned, it also affects other parts of your brain. And ultimately it will impact on your ability to day-to-day functioning. Not only your ability to live independently, but it also may affect your ability to live alone safely. So if we try to kind of preserve your mental function as much as long as we can, then we preserve your ability to live safely in a home-like environment as long as you can. What this medication does is basically so anytime you see the word A's, acetylcholinesterase, and then anytime you see a word that ends in A's, we know it's an enzyme. So it's a kind of product in your body that uses to kind of part of a chemical reactions in your system. It kind of enhances or starts catalyzes chemical reactions in your body. And what acetylcholinesterase does is the enzyme that breaks down the brain chemical called acetylcholine, which is kind of what we call the memory chemical. Generally, what happens is that the brain makes acetylcholine, it serves a function, and then it's recycled by the enzyme, so that it's kind of not used again. But because with Alzheimer's disease, that whole process is diseased. When you break down and recycle the acetylcholine, you may not have much to produce to replace it. So we want to try to preserve as much of it as we can for as long as we can. And so that's basically what the acetylcholinesterase inhibitor, the medication, is used to do, is to inhibit the enzyme which recycles and breaks down the memory chemical, acetylcholine. Okay. As I mentioned, the medications do not stop Alzheimer's disease, and the whole idea is to try to slow down the progression of the disease. And this is just a diagram to show you kind of, from one brain cell to the next brain cell, you have acetylcholine in the brain cells, and how it communicates with its neighbors is using the memory chemical acetylcholine. And the area between the two knobs there is called a synapse or synaptic cleft, which is the area between two brain cells, neurons, and they communicate when they kind of using chemicals to communicate uh, from one neuron to another. And as you can see, that acetylcholinesterase is the enzyme that's in the cleft, synaptic cleft, or the synapse part of the neurons. And it's there that you block the recycling of the acetylcholine, the memory chemical, so that you have more of it around to kind of do more memory, to kind of participate in more of that process of memory. Um, there are a number of medications, well, three medications in this category. The first one, and the one that's been around the longest, at least in Canada, is called donepezil or Aricept. It's a once-a-day medication. Um, Normally, we start off at 5 milligrams a day, and then increasing to 10 milligrams a day a month or so later. I don't always increase the dose to the maximum dose, because as we increase the dose, there is also increased risk for side effects, which we'll talk a little bit more about later. However, there is also some speculation from some experiments and studies that shows that 10 milligrams may not afford a whole lot of advantage over the 5 milligrams, but at the expense of more side effects. So some people, I don't go above 5 milligrams. There was a study about now 6 years ago where they looked at 23 milligrams of Aricept for people with Alzheimer's disease. There was one study to show that there was benefit. I haven't seen a lot of reproduction of this study, and I'm actually a slow kind of converter to new drugs and things like that. So one of the things that not only did I was somewhat speculative about the 23 milligrams dosage, because it is a fairly high dose. So, if there's concern about side effects at 10 milligrams, and there would be concern about 23 milligrams. But the one kind of big study that came out of it, the 23 milligrams showing that it's effective. Again, one, I'm a bit concerned because it hasn't been repeated. Two, the other thing that it makes me a bit suspicious is why 23 milligrams? So when we look into it a little bit more detail, we find that this study came about the time that donepezil actually started to lose its patent. So meaning that generic brands would be available. And the 23 milligrams study was interesting because at that time, they found that that was effective or helpful for some people enough that they can actually market it as a 23 milligrams. Then right now, between the 5 and 10 milligrams, there's no way that you can use a 5 or 10 milligram to make up 23 milligrams. So the whole premise for this study was because its patent was running out. So, which is also not very good optics, but certainly not only in that itself, the fact that there's only been one study, I haven't seen many kind of other studies to kind of reproduce this, means that myself and many of the experts that I know of in Canada really don't use the 23 milligram at all. Rivastigmine or Exelon is another class, another one in that class. Is a medication that is twice a day dosing. And I don't really use this one very much. And it also has the unfortunate reputation of causing more stomach side effects than its brethren in this class. However, I think that that's a kind of a bit biased, because initially when this medication was marketed, it was marketed as a medication that you titrate upwards or add upwards every 2 weeks, while the other medications were every 4 weeks. So there is a very high likelihood the reason why people during the studies had more side effects was because the time to increase the dose was actually shorter than the other ones. And if your body had more chance to get used to it, it probably wouldn't have caused as much stomach side effects. But there you go. It's kind of been labeled with that kind of bias, unfortunately. Because it's a twice a day medication, I don't tend to use it very much, because I find myself that I have trouble taking one medication a day, let alone 2 medications a day. So I don't use it as much. Excuse me. But the times that I do use it, and the reason why I use it is because it, unlike the other medications, um, excuse me, can come in a patch. And the reason why that's important is because with the patch, it bypasses your stomach. So for people who have can't tolerate the oral medication, um, who have stomach problems because of the medication, using the patch can bypass that problem. Now, having said that, I also do have some people who, even with the patch, they still have side effects. Um, but generally, it is a good option. The only problem is that the patch right now is still not covered, as far as I know, in Ontario. Uh, Things might have changed, but not that I'm aware of. So the medication, the oral medication, that the pill that you, sorry, the capsule that you take is covered, but the patch is not, is my understanding. In addition, unlike the two other medications in this class, in this family, rivastigmine is kind of cleared, metabolized, cleared by your kidneys, and so therefore your kidneys need to be working fairly good to use this medication. And then you have galantamine or Rimonil, which is kind of the newest of the three. And when I say new, I use that softly because these medications have been in use for some couple over 2 decades. But Remonil is another one that is on that is often used. Start off at 8 milligrams, 4 weeks later go up to 16, 4 weeks later go up to 24. Again, I don't use this one as much. Just because Aricept's been around longer, the data for safety and effectiveness is much more available, and more and certainly more studies have been done on that medication than other ones. So I don't necessarily use galantamine a whole lot, but again, it's another option to try. The common side effects of this family of medications, of these three medications, include, as I mentioned before, kind of more stomach-related side effects, so things like nausea, vomiting, diarrhea, losing appetite, but sometimes also non-stomach-related side effects like muscle cramps, fatigue, and certainly for donepezil or Aricept. Even now in the Canadian pharmaceutical kind of Bible, the CPS, it still suggests taking it at nighttime. But we do find that sometimes taking it at nighttime, especially with donepezil, people may experience vivid dreams, which may impact their ability to sleep or cause sleep disturbance. So which isn't very great. So so even though the CPS says to take it at nighttime, many of us who work in this field suggest people take it during the day, especially about an hour or so after breakfast or lunch. Which when you have a full stomach, it also cuts down on the stomach side effects as well, which is not, which as you saw is common in this drug group, or one of the common side effects. I shouldn't say it's common, but it's common side effect if you're going to have side effects. There are some people where this medication can also slow down their heart rate. So oftentimes before we start this medication, we do ask family doctors to kind of get an electrocardiogram or heart tracing to make sure that the electrical conductivity of the heart, conduction of the heart is generally normal, and that there's no significant electrical problems. In addition, other people who may not be good candidates for this class of medication includes people with severe asthma or COPD, or people who've had recent bleed in their stomach because the medication cause increase in acetylcholine, but acetylcholine isn't just a memory chemical in the brain, it is also in the heart and the lungs and the stomach. And when you have increased acetylcholine in your lungs, it increases secretions. So if you have asthma or COPD, you certainly don't want to have more secretions, because that will cause more trouble for breathing. Similarly, in your stomach, if you have more acetylcholine in your stomach, it increases acid secretions and may increase your risk for stomach bleed. And certainly, if you had a bleeding ulcer recently, this medication may not be a good fit for you. So besides the class of acetylcholinesterase inhibitors that we talked about just now, there is another class of medication, a medication called memantine. I should say class, it is a class by itself. Memantine or Ebixa. It was approved in 2003 for the treatment of moderate to advanced Alzheimer's disease. And it's a medication that is still not covered in Ontario, and it costs about $150 to around $200 a month. I can't remember exactly how much it is now, but it's certainly at least $150 or more a month, unless you have a drug plan. It's a medication that I don't actually use alone very much by itself, unless there's some reason that a person cannot take an acetylcholinesterase inhibitor. Having said that, there has been some limited studies to show that when combined with an acetylcholinesterase inhibitor, so combination therapy, that the combination may work better than either one of these medications on its own. Having said that, my own experience has been that I've been underwhelmed by the combination therapy. So, and plus the fact that most seniors are on a fixed income and I can't afford an extra $150 to $200 a month for a medication that may not work or moderately work at best. I don't use this medication a whole lot. In addition, just as for your information, this medication also requires your good functioning kidneys to use as well. Okay, so we kind of talked about that. And then dosing is you start off with 5 milligrams a day for a week, and then go up to 5 milligrams twice a day. And then every week thereafter, you increase it by 5 milligrams until you reach the optimum dose of 10 milligrams twice daily. Not only memantine, but really kind of for the acetylcholinesterase inhibitor, anecdotally, from my own experience, is generally well tolerated. But memantine also, like any medication, has common side effects, which include things like dizziness, headaches, high blood pressure, constipation. And if we increase it too quickly or too high of a dose, sometimes people can become confused. And some people can actually have hallucinations and just not do well with the medications. This is just kind of a slide to show the development of these memory medications or medications for to manage Alzheimer's disease specifically. This is this older slide that kind of showed that alternative medications, actually, sorry, non-pharmaceutical medications. So things like ginkgo biloba and other things. But really, there's nothing in this list that has shown any significant improvement other than probably huperzine A. But it's actually been a number of years since I've seen anything come about huperzine A. Is a Chinese moss extract that its active components is similar to the acetylcholinesterase inhibitors, but I haven't seen very much coming out of about this in the last number of years. The study about curcumin is still, I believe, in the process of being reviewed and examined, so I don't have anything new to say about curcumin. There was a kind of a big study with ginkgo biloba done a number of years ago. It was a 6-year trial, with thousands of patients, different sites, and it really showed no benefit using ginkgo biloba. Antipsychotic medications, I'm just being mindful of the time. So we have about 10 minutes or so left. So I'll kind of go through this a little bit quickly. So antipsychotic medication. So this is kind of the section where we talk about complications of Alzheimer's disease. So what are some of the things that are not related to memory, language, perception, things that can cause complications? So as I mentioned before, we can see behavioral changes. We can see neuropsychiatric symptoms like hallucinations, paranoia, what we call delusions, which are false fixed beliefs. So, my spouse is having an affair or things like that. Antipsychotic medications are medications that originally developed for schizophrenia, which is a psychotic disorder. But we do know that schizophrenia isn't the only condition that causes people to become psychotic, like paranoid or hallucinate. We know that depression can cause that. Manic depression can cause that. We know that delirium can cause that, and certainly people with dementia that they can have symptoms like that as well, or non-cognitive, or what we call neuropsychiatric symptoms. And because sometimes people have paranoia and hallucinations to a degree that is very, very uncomfortable for them and it causes significant problems for caregivers as well, we do sometimes use these medications. Um, and one of the times that we use these medications are not only for psychotic symptoms, but also for people who have uh, changes in their personality and behaviors that are very problematic. So people who become physically aggressive, um, though we sometimes use this type of medications to try to limit the intensity and the frequency of the triggers that cause that kind of physical aggression. Um, However, having said that, we also have to keep in mind that complications of dementia, whether it's aggression, wandering, depression, anxiety, what have you, those are not uncommon. And in fact, somewhere along the ways, about 80% of people with Alzheimer's disease or other types of dementia will run into some kind of complication. So if you have a loved one who has the dementia and they're going through a difficult time or having difficult symptoms, you're not going to be the only one. And more times than not, people will have some kind of challenging behaviors. Sometimes it's managed by medications, sometimes not. Either way, whether you use medication or not, the most consistent approach is to look at non-pharmaceutical and non-medication interventions. So looking at behaviors, how do you approach the person, can you modify the environment, things like that that hopefully will mitigate the intensity and frequency of these challenging complications. Um, the most times that we see these symptoms are in long-term care. However, we see many of these in the community as well. We do know that as the disease progresses into the middle to later stages, that the likelihood of these symptoms will rise. But we also have people in the early stages where there are challenges as well. We also know that depression can be very common with people with Alzheimer's disease or dementia, especially those in long-term care. Studies have shown that up to 50% of people with dementia in long-term care may present with depression. Anxiety or worrying about things can also be present. Both of these conditions we can use antidepressants to manage. There are sometimes mixed studies to show whether antidepressants are helpful or not. I would say from my own experience that depression is something that can be managed with antidepressants. Not can always, but certainly more times than not, it's more beneficial than not. Um, and when you have paranoia and hallucinations, as I mentioned before, you treat that with antipsychotic medications, and you use those medications for agitation and physical aggression as well. So depending on the complication, you do use different classes of medication. But again, I can't stress enough that when we deal with complications of dementia, although we're talking about medications, we really try not to use medications. We really try to use a non-medication approach to kind of help them deal with these triggers, because there's oftentimes their brain reacting to something rather than they're being bad people or what have you. So irregardless, like I said, whether we use medications or not, we really want to press upon caregivers to use a non-medication intervention first, and at worst, in combination with medications, but never without trying an approach or having an approach as part of their intervention. Okay. Just to kind of reiterate, all medications have risk for side effects. And although, there are common newsprint articles every couple of years will kind of replay kind of concerns about antipsychotic medications or psychiatric medications. We do know that there was a large study that was done in the New England Journal of Medicine, that was published in the New England Journal of Medicine about, again, 5 or 6 years ago now, that showed that many seniors who present to the emergency department don't present with issues with psychiatric medications. The medications that cause the most problems for seniors are actually blood thinners and diabetic medications. Those two medications cause much more emergency room visits than psychiatric medications, although psychiatric medications get the most bad press compared to other medications. We do know that especially antipsychotic medications in seniors with dementia, there is a slight association of mortality and morbidity, which means that for whatever reason, seniors with dementia who take antipsychotic medications seem to be at high risk for developing kind of complications like pneumonia and even stroke, which in these conditions, in seniors, these conditions can cause death, or what we call mortality. So they can cause, and that increase is about the absolute difference between seniors with dementia who are on those medications versus those who are not are about 2%. So it's about 2 in 100. I mean, so it's not big, but it's significant enough that we tell people about it. But certainly you wouldn't want to be that 2%. Having said that, we also have to keep in mind that people can also be hurt when complicated complications are not addressed. So people can fall, get into accidents, or have other misadventure because they're reacting to what's triggering them. So we have to kind of keep that in mind too. So it's a risk-benefit analysis, and at the end of the day, our job is to kind of give you the pros and cons and the options, and your family and your loved ones will have to make the decision based on whatever value is most important for you. So I'm not going to talk about the future directions because right now things are a little bit up in the air, and also for the interest of time. So all I'm going to do is I'm going to forward to the end at this point in time, and to probably open it up sometimes a little bit of time for questions instead, if that's okay with you, Sandy.
Sure, that should be okay. There are several questions, and so I wonder if we may not get time. You may not get time to answer them all, and perhaps if participants want to hear the questions, maybe if they want, maybe 10 minutes. It'll take 10
Sure.
minutes.
Okay.
And okay, that'd be
Okay.
great. Yeah. So you can read the questions. Is that right?
Let me see.
Okay.
The questions. Let me see. Okay. Question. Okay. Is someone with Lewy body dementia able to manage the diabetes on their own, or do they lose their ability to manage the insulin and sugar levels? The question is yes, possibly. And the reason why is it depends on the stage of disease. So at the earlier stages, they may be able to do it, but as the disease progresses, then their ability to organize kind of everything that's required to take medications properly and on time becomes compromised. So it really depends on the stage of the disease. Okay. Are having turmeric herb or chlorophyll herb or being more active preventing of having dementia? So turmeric and chlorophyll, turmeric is kind of not sure. So they're doing that study on curcumin. Chlorophyll, I have not heard anything. Active lifestyle, yes, active lifestyle is helpful because it decreases risk for things like cardiovascular disease, which is a risk for dementia, Alzheimer's disease. We do know that the Mediterranean diet, there are some positive findings of the Mediterranean diet being helpful in preventing dementia. We also know actually using hearing aids can actually be helpful for possibly prevention, and there's more coming out about that, and I think the evidence is actually quite impressive to the point that I myself actually got hearing aids last year. Because what we're finding that is that if once you start losing kind of your ability to hear, it actually some of the nerves, that the active nerves become less active, and for whatever reason, that's kind of been associated with increased risk for dementia. So make sure, if you're having hearing problems, one of the things that you could do is actually, on top of keeping healthy, eating properly, moderation, less alcohol, no drugs, meaning like, although marijuana is like legal, probably avoiding marijuana and stuff like that, and living a healthy, moderate lifestyle is probably beneficial. And if you're having hearing problems, yeah, go get your hearing checked and try to wear your hearing aids. They're not yes, they're a pain in the butt sometimes, but some of the newer models are really quite good. The ones that I have are actually quite good. So I'm just a bit sometimes lazy to put them on. I'll admit I'm not a good patient, but yeah, hearing aids for sure. Vascular dementia, what is the timeline to likely death? Similar to Alzheimer's? It really depends because, as I said, that the thing that sets vascular dementia apart is the cardiovascular risk. And once you've had a stroke, there's a high likelihood that you have another stroke. And the strokes can certainly increase your risk for not only further medical complications, but certainly could cause death as well. So I would say it's variable, but kind of looking at the odds, I would say people with Alzheimer's disease may likely have a little bit longer lifespan, natural lifespan, if barring any other confounding variables. How long is Aricept effective for once diagnosed? So again, that's hard to say. The rule of thumb is probably around 2, 3, 4 years, but it kind of is it's really hard to say. I've actually had clients who've been on Aricept um, for like 5, 6 years, and their scores have dropped minimally. They're still functioning with some assistance at home, um, generally, fairly safely. Again, it's kind of variable, but I think the rule of thumb for most of us are, it's probably to have some benefit for at least 2, 3, 4 years. There was a study from Sunnybrook about 7, 8 years ago now, where they showed that even people with middle to advanced stages of Alzheimer's disease, the medication may be helpful, not so much with preserving memory, but actually preserving function, meaning that even with assistance and care, the medication will allowing the client to follow directions, to be cued to do things, rather than needing more hands-on care. So there is possible. So that's why Aricept in Canada has been given an indication for use in middle to later stages of Alzheimer's disease, where initially when it was first marketed, it was only for mild to middle stage disease. Okay.
Thank you, Dr. Lamb. I think we have time for one more question.
Okay. So the medication question, I think I've already kind of indicated in terms of effectiveness and benefit, and different stages and stuff. But parents, if one of the parent have a dementia, which it's genetic, does it make sense to start the medication earlier? Um, so, so the question for that is, for if it's sporadic and you have the gene variation, the answer would be no. Because and the reason why that is that sporadic form of Alzheimer's disease, people oftentimes go through the mild cognitive impairment form or the mild neurocognitive disorder part of this disease before they move into the major dementia category. And we know that there was studies have been done. I think the last one was from the Mayo Clinic, where it showed that people with mild cognitive impairment, when they took medications like Aricept, not only did it not decrease the kind of the risk for Alzheimer's or progression to Alzheimer's disease, but actually increased mortality, because as I mentioned before, there are side effects to this medication, including slowing the heart rate and so on and so forth. So people who had only mild cognitive impairment actually did worse in terms of outcomes, a little bit worse in outcomes when they took it. So from that perspective, in regards to the familial form of Alzheimer's disease, I think that by the time that early Alzheimer's disease is picked up, which is like in your late 40s, early 50s, it's already kind of self-explanatory. And by that time, you would start them on it anyway, just because you try to do what you can for those early onset form of dementias. So that kind of for people with the early onset or familial form of Alzheimer's disease. So it's kind of different answers to whether it's a sporadic form or early onset form.
That's great. Thank you very much, Dr. Lamb.
Yeah.
Lots of great information. It has been recorded, and we will be sending it out. Lots of questions too. I'm sorry we didn't get to all of them, but we will ask Dr. Lamb to answer some, and we will send it out in an email. So next week, I think you'll be really interested. Two of Dr. Lamb's colleagues will be speaking about understanding changes in behavior. So Dr. Lamb has given a fabulous overview of medically what's happening, and the colleagues will be giving an overview of why are the changes, what's happening to the behavior, and what can we do about it. So just before you go, if you wouldn't mind, I'm going to turn a little poll on. And if you wouldn't mind answering the 3 quick questions, we would appreciate it very much. And otherwise, we will thank you, Dr. Lamb, and we will see you next week.
Take care.